Good afternoon, everyone, and welcome to Trinity Health of New England's Orthopedic Movement Matters webinar series. We appreciate you taking the time out of your busy schedule to discuss some orthopedic-related topics with us. Please remember to mute your microphones, and that can be done on the top of your screen. If you just click the microphone, and once it's muted, there's a little slash through it. My name is Dan Gould, and I will be your host for today's webinar. We plan to present as an ongoing educational series on the second and fourth Thursday of each month from 5 to 5:45. Today, our guest speaker is Dr. Chad Daniel. Dr. Daniel is an orthopedic surgeon at the Connecticut Joint Replacement Institute here at St. Francis Hospital. Dr. Daniel will be speaking about current treatments for knee arthritis. We'll have a presentation followed by some questions and answers. And as you can notice in the chat box, I submitted the anonymous link. So if you'd like to submit some questions anonymously, feel free to click that link. If you don't mind having your questions be seen by other attendees, please use the chat function. So without any further delay, let me turn it over to Dr. Daniel, and we can get started. And Dr. Daniel, you should be able to unmute yourself, and we should be good.
Perfect. Thank you, Dan. Can you hear me okay?
Yes, sir.
All right. Well, I want to thank everyone for taking the time to come and listen to this talk. We're going to be going over just kind of the basics of knee arthritis, the different causes of it, the different types of it, and what the current treatment options are for it.
And I will just interject that Dr. Daniel is in Manchester and Rocky Hill, so he is in multiple locations. So any questions you have, his office numbers are listed here, and I can include a link in the chat just if you want to reach out again. And then anonymous questions are in the chat function, so I'll give it back over to you.
Perfect. All right, so we'll start out with just the really basics of it. So in general, what is knee arthritis? Knee arthritis in a basic sense is just inflammation and damage to the cartilage inside the knee. So your knee is covered on the inside with these smooth, slippery surfaces that allow the bones to glide smoothly past each other so that we can move our knees freely without friction and without pain. And for whatever reason, whatever the underlying cause of it is, the cartilage starts to become inflamed and starts to break down. And when it breaks down, those surfaces then become rough and it causes the whole knee to get irritated and inflamed. And it inhibits and stops the knee from moving as freely and as smoothly, and it creates a lot of friction, which in turn creates a lot of inflammation, which is where pain usually comes from. Next slide. So the typical symptoms of knee arthritis, they can be very variable. So most patients in general complain of a lot of pain. That pain is usually worse after increasing activity. Patients will notice that their knee is very stiff first thing in the morning, and after they take a few steps, that stiffness kind of resolves, but they notice that the more and more they go, the more they walk, the more that pain becomes really intolerable and starts to limit the amount of activity and exercise they're able to engage in. They may also notice that the symptoms come and go. Some days the knee feels really good, and other days the knee not so much. You know, they can go out and have a nice, good, active day one day, and then wake up the next day, and the knee is all irritated and inflamed. There's a lot of swelling involved at times. And patients notice that as the arthritis progresses, they have more difficulty with those higher level activities that they used to enjoy, and the symptoms can even progress to the point where they interfere with simple everyday activities. All right, next slide, Dan. So what kind of types of arthritis are there? So when we talk about our knee arthritis, we generally talk about three typical causes. So osteoarthritis is the main one that I would say the vast majority of patients come in with. This is more of the wear and tear type of arthritis. It's just generally due to using your knee, existing, living, going and doing the things you like to do. And for some reason, some patients are more pre-genetically disposed to it. their cartilage breaks down a little bit quicker, whether that's due to their natural alignment of their leg and the stresses and pressures that get put across the knee, or whether that's just due to, maybe they sustained a little injury when they were younger. The second type is post-traumatic. Post-traumatic is usually associated with an identifiable injury. So this is somebody who has had a fracture in their knee in the past that had to be repaired, or somebody who may have had an ACL injury in the past, and this creates an initial damage to the cartilage. The cartilage has a very, very poor blood supply, and therefore it is not able to heal itself very well. So when it sustains that initial injury kind of gets the ball rolling and sets off the cascade that leads to more cartilage breakdown and leads to the people developing arthritis in their knee. The third and final category is inflammatory arthritis. Inflammatory arthritis is a little bit of a different beast. It's usually due to an underlying medical condition, an autoimmune disorder. This is things like rheumatoid arthritis. This is gouty arthritis. This is, psoriatic arthritis. Usually patients are seeing a rheumatologist for these diseases, and we usually start by getting a handle on the arthritis by addressing the underlying autoimmune disorder and then dealing with any of the residual symptoms from may have already occurred in the knee to the cartilage. So what can we do about it? Current treatments, as of right now, medicine hasn't advanced to the point where we can reverse any of the changes from arthritis. Not only does the cartilage break down, but when the cartilage starts to break down, it creates increased stress across the joint, and it leads to your body remodeling with bone spurs and extra bone being laid down to try and spread out those forces. In addition to that, it creates this really thick, dense bone, and you can actually get little cysts inside of the bone, all due to the arthritis. So there's no way to reverse those changes. People have tried to replace the cartilage and just try to regrow. And again, it doesn't change the underlying bony changes. Right now, treatment mostly consists of symptom management. So finding things that allow you to decrease your pain and allow you to continue to do the things you want to do in life, until eventually, which may or may not occur, that a patient may consider knee replacement, which is what we consider the only cure for knee arthritis. So again, our goal is to do everything we can to maintain your current lifestyle and hobbies and save surgery as a last resort. So the first thing we can do is lifestyle modification. So we know that arthritis is caused by stress across the knee. So by finding ways to decrease the amount of stress across the knee, whether that's avoiding any aggravating activities. Some patients will notice that it really flares up on them when they go out and walk 18 holes and play golf, or whether they're playing tennis. So they either play with a cart, they back down to 9 holes, things like that. People need to avoid high impact exercises. So, running and doing things like jumping up and down typically are not good because it increases the amount of stress across the knee. The other thing people can do is losing weight. They say that every 1 pound of body weight that we lose is 5 pounds of pressure off the knee, which, add it all up, 10-pound weight loss, 50 pounds of pressure less off the knee. It's taken a lot of stress off of it and help decrease your symptoms. Physical therapy is another lifestyle modification that helps to decrease the symptoms by strengthening the muscles around the knee. If our knees are stronger and the muscles around our knees are stronger, then it can, again, take some of the stress off the knees. Next slide.
Dr. Daniel, can you see the supplement slide?
No, I don't see that. Are we able to go to the next slide? I'm stuck on lifestyle.
Let's try that.
I got assistive devices now. Did we skip one? There we go. That's perfect. Okay, so the next range of categories is supplements and other natural remedies. These are a lot of things that I get asked about in clinic a lot because people want to try things that are not medications, which is completely reasonable, right? Like the less chemicals we're taking in, the better people tend to feel about what they're doing. They also want to be able to do things that can help prevent it from progressing. So one of the products out there that's marketed as joint health and trying to prevent further damage is glucosamine and chondroitin. They're frequently packaged together. It's a supplement like OsteoBiflex is one brand name that, you know, we have some patients that say that they get good pain relief from it and helps them with their knee function. But for the most part, the literature and the data on these is pretty mixed. The other products listed below it kind of fall in the same thing. Fish oil, turmeric is listed as an anti-inflammatory supplement that people like to take. Some people swear by cherry juice. Other people will try CBD oil as an anti-inflammatory that they can topically place over the knee, put it on their skin and rub in. Again, these are all things that the literature doesn't feel strongly one way or another. You know, they're the type of things that people, it's okay to try. But typically I don't recommend people spend a lot of money chasing these down and trying to add them in when the research on them just shows that it's very individual results. Right, next. Are you able to change slides, Dan?
Yeah, showing on my screen.
No, not on mine, unfortunately.
We can see it too.
We're seeing assistive devices.
All right, so assistive devices, these can be very helpful. So these can range from anything from a compressive knee sleeve, something as simple as a simple elastic or fabric knee sleeve that can provide a little compression to the knee. These help patients feel a little bit more stabilized. Typically, the metal hinges are a little bit of overkill. People find them to be very uncomfortable. The more constraint to the device, the more uncomfortable it tends to be. And honestly, the less people tend to use it. So we typically start with very simple and can work our way up. This brace shown here on the right is something called an offloader brace. So when we wear out our knees, it's usually one side, the inside or the outside. So one side or the other is the side that's receiving more pressure. So this is a brace specifically designed to put pressure on the other side of the knee to try and shift the pressure over to the less effective side and take some pressure off of the side that is more worn out. They can be effective. The problems with them can be that sometimes patients can get a little skin irritation underneath that pressure point, that it is the brace pushing on your knee, so it can cause some skin problems. Some patients do find that some medication or a walker or a cane can be helpful too if they feel uneasy on their feet. In terms of medications that can help, typically topical ointments are the easiest thing to try. These can be things like Icy Hot Bengay. Voltaren gel is like a topical anti-inflammatory like an ibuprofen that some patients will try. There's less systemic absorption. So for patients who are taking medications that have contraindications to taking ibuprofen and other non-steroidal anti-inflammatories, that can be an option. Tylenol works specifically just to address pain. It doesn't do anything for the underlying inflammation in the knee. It's just trying to decrease the amount of pain. The non-steroidal anti-inflammatory group, the NSAIDs, is a very broad category. There's a lot of them. These are anything from Advil, Aleve, ibuprofen. Some prescription ones are diclofenac, Celebrex, meloxicam. And the idea behind these is that they're working to decrease the inflammation in the knee. If we decrease the inflammation, we can get rid of some of that swelling, some of that stiffness that patients complain of, and some of their pain. Tramadol is one medication that is actually has some backing from the Orthopedic Academy on using this for arthritis. It's a little bit of a light narcotic technically. It doesn't have as many bad side effects as our heavier narcotics. It's one we try to stay away from even with the recommendation just because, you know, a lot of patients don't like the way that it feels, and it does have some addictive properties. So patients with their inflammatory arthritis, again, those are a little bit of a different category, and they work with their rheumatologist to target and find the proper drugs to help with that. All right, so injections. Injections are probably one of the fastest and easiest ways to help get some immediate pain relief for patients who have a lot of knee swelling and pain. Cortisone is usually our first line. It's a steroid medication. It works to address underlying inflammation. If we get rid of the inflammation, a lot of the swelling and stiffness in the knee goes away, and patients can get back to doing what they want to do. Cortisone injections, kind of have a bad rap. A lot of people think they're pretty painful. Most patients really complain of more of a pressure when they're getting the injection. People often worry, and rightly so, about creating more damage with them. As long as they're spaced out properly every 3 months, the knee and the ligaments inside the knee have a chance to recover, and the damage that people are worried about receiving is really minimized. And there's no lifetime maximum number as long as they're appropriately spaced out and they're still effective. Hyaluronic acid is kind of the newer generation. They've been out for a little while now. These are what people used to refer to as the chicken comb injections. Other people call them the gel injections. They're a little bit more expensive. Most people need prior authorization from their insurance company. So if this is something patients are interested in, they typically cannot get it the same day. They have to come back for it. They're a little bit less reliable. So we say cortisone helps about 95% of patients with an injection if they have knee arthritis. The gel injections are more like 60 to 70%. So there's a significant number of patients who come back and really say that they didn't have much relief from it. But for those patients that they do work for, they tend to last longer. These injections can be repeated every 6 months. That's how often the insurance company will pay for them. And then the last two are really PRP and stem cell. These are ones that I think people have a lot of hope are going to change things and give us some more options down the future, but the literature is really lacking on them, and the insurance companies are not paying for them at this point. They're very expensive out of pocket. They're several thousands of dollars, and it's really hard to make recommendations for patients to try these when there's really no guaranteed better results than the other injections at this point. So finally, surgery is kind of our last line. Arthroscopic surgery. So this may be appropriate for select patients. The idea behind arthroscopic surgery is to go in and clean up the knee a little bit. So the meniscus is typically what gets damaged inside the knee. The arthritis can't be removed with the surgery. Just, a lot of people say that their surgeon went in and cleaned out their arthritis, and arthritis is wearing away the cartilage. It's not something that's added that we can take out. It's something that's already missing. So the surgery really addresses more of meniscal damage. The problem with that is that for patients who their arthritis is severe or has progressed to the point where there's actually starting to have changes and inflammation in the bone, that this arthroscopic surgery can make their symptoms worse, or, at the very best, they won't get much relief from it. Another thing that's kind of on the forefront is cartilage replacement surgery. This is typically reserved more for our younger patients. So this is, younger athletes that have had an injury and there's damage to the cartilage. They do have ways to kind of grow it in the lab or take some cartilage from another place in the knee and place it and kind of patch it in. Once there's arthritic changes and there's bony changes inside the knee, you start getting the bone spurs or the dense white bone inside the knee. These surgeries really aren't an option. Finally, knee replacement. This is what we kind of refer to as the cure. So we actually go in and we remove all the cartilage. We take out the joint space, we take out the arthritis, and we replace it with a mechanical knee. So this consists of usually 2 metal caps, one on either side of the bone. There's a plastic liner that goes in between and something behind the kneecap. Partial knee replacement may be appropriate for select patients. It's usually patients that we talk about the knee having 3 different compartments: the inside, the outside, and behind the kneecap. It's for patients whose arthritis is limited to just one of those compartments. And it's usually that inside compartment. It's that inside part of the knee that usually gets the partial knee replacement. Very rarely, some patients will get a kneecap replacement. But this is a mechanical knee that basically removes the arthritis, takes the joint out, and replaces it with the metal and the plastic. So that leads us to how long do they last? So this can be very variable. So it depends a lot on a patient's activity level. Our younger patients who actually need them to last the longest typically wear them out the fastest, because these are our patients that have the greatest expectations for their knee. These are the patients that are going to push them a little bit harder. These are the patients that want them to do more. And what happens is that eventually over time, that plastic liner starts to wear out between them. That said, they're lasting longer all the time. Those plastic liners got upgraded about 20 years ago, and a lot of those knees are still going strong. We're not seeing the same wear problems that we saw with the older generation knees. The partial knee replacements, unfortunately, don't last as long. We're hoping for 5 to 10 years out of those partial knee replacements before either the partial knee replacement wears out or you start to develop arthritis in another part of the knee that requires the partial knee replacement to be converted to a full knee replacement. And that leads us to if anybody has any questions.
So I received a few, Dr. Daniel. So the first one I have here, so you mentioned a popping noise in their knees. This person hears a clicking with each step. What does that mean?
So there can be a lot of different reasons that knees can pop or click. Most of the time it's because the lining of the joint is inflamed. So beyond just the cartilage getting inflamed with arthritis, there is the inside lining of the joint. It's called the synovium. Its job is to make the lubricating joint fluid inside the knee. That becomes very irritated and it gets larger because it's inflamed, and that can kind of get caught between the kneecap or in the knee. The other thing that it could be is it could be the meniscus can kind of, when the cartilage wears out, that meniscus lives in between those cartilage caps. And when that cartilage wears out, the meniscus kind of gets pushed out of the knee joint. And so it can be the meniscus popping in and out. Those are typically the two most common causes.
After I get a knee replacement, are specific activities limited, such as running, racing, or tennis?
So you are able to do about whatever you want to do. So running specifically, we have some patients that want to run for exercise. That's typically not a recommended activity after knee replacement. That knee replacement is a mechanical knee bonded to your bone by some method, usually a cement or getting your body to grow into it. And that repetitive pounding of running can help to loosen and rock that knee free earlier than it should. Tennis is okay. We have a lot of patients that play tennis. We have a lot of patients that play golf. Skiing and other downhill activities like that can be a little bit higher risk and can be difficult. But for the most part, with the exception of the high impact activities like running, they tolerate most things pretty well.
Great. Linda, I see you have a question. If you'd like to unmute yourself and ask Dr. Daniel.
Sure, thank you. I'm 53, and my doctor and I recently had a conversation that basically I've tried all of the less invasive options besides surgery, but I know some doctors will say, oh, that's too young to have a knee replacement. What's your opinion when it comes to age? I was happy to hear you say that things are lasting longer than before.
Yeah, absolutely. So we're finding that, newer products are making to the market before the older products have worn out at this point, which is a good thing. But in terms of age, I don't consider age a contraindication to surgery. I think that for our younger patient population, that they should exhaust all their other options. But I have a really hard time telling a patient who is in pain and can't participate in the things they want to do, sorry, you're too young, come back in a couple of years, good luck. It's one of those things that, I think you need to enter into that with a little bit more caution. It should be the last resort for a younger patient, especially 53 years old. But I'm not against it if we've exhausted all other measures and the patient, their lifestyle is suffering.
Thank you.
Dr. Daniel, what is the recovery process and time after a total knee replacement surgery?
So it's very variable. So a lot of this depends upon your definition. I tell patients this all the time. When they ask how long is the recovery, well, that depends upon your definition of recovery, right? So every patient we want out of bed walking the same day surgery. You need a walker to do it, but we want you out of bed walking the same day. We start your rehabilitation right away. And then a lot of it's just waiting on time to healing and working to get your strength and your motion back. Most patients are really feeling pretty good by about the 4-week mark. We hope to get most people back to work by 8 weeks. Most people are back to, playing golf and playing tennis by about 3 months. I tell patients 12 to 18 months for full recovery though. And what I mean by full recovery is that kind of the quirks and the, your body getting used to having a new mechanical knee, those symptoms have kind of settled down. We get a lot of patients that come in after 6 to 8 months after surgery, and they're like, listen, I went to Disneyland this weekend and I walked around and I put in 10 miles walking on this knee and it felt great. And then the next day I woke up and my knee was painful and swollen. And those kind of things are symptoms that take, 12 to 18 months to really kind of slowly progress and move beyond.
If one hears a clicking or popping when walking, should you avoid taking longer walks?
I think that's very person dependent, right? If that clicking and popping is painful, then yeah, you should be looking to do something about it. But you don't want to become, sedentary. We don't want patients sitting around. I like to say that knee arthritis itself is not dangerous. It only becomes dangerous if you become sedentary and inactive because of your knee arthritis. If you start spending all your time sitting around doing nothing, avoiding being active because your knee hurts, well, then other health problems are going to start to come up. So if that popping and that clicking is really just more of an annoyance and it's not causing pain, absolutely not. Go out, do your walks, go do the things you want to do. If it becomes painful, talk to your doctor, find a solution, try to get that pain to go away so that you can stay active and healthy.
What would you tell someone who is a little bit nervous to get surgery or get a knee replacement?
I would tell them they have to be ready for it. It's a commitment. It's a long recovery process. It's a big surgery. The patients that do the best are the patients that show up and say, I want to have surgery. It's not the patient that we have to talk into it. It's not the patient that is a little hesitant. You have to be ready for it, and you'll know. When your pain progresses to the point that you're no longer able to engage in the activities you want to do, and you're missing out on all the good things life has to offer because your knee hurts, then you'll know. You'll say like, okay, I'm tired of this. I need to do something about it. But, the vast majority of patients do very well. Our complication rates in these surgeries have gotten better all the time. I would say 95% of people, 99% of people do very well.
Great. Can you talk about, so it looks like a patient hears some cracking when their knee bends. Can you talk about what that might possibly be?
So again, the cracking in the knees can come from a lot of things. It's either probably some inflammation inside the lining in the joint that's getting caught in between, or it could be from the meniscus popping in and out. Usually it's not a tendon snapping or popping or anything like that. It's usually something else is inflamed, or that meniscus is getting squeezed out.
Why are some people able to kneel after knee replacement and others find it painful?
That is a $1 million question that unfortunately medicine does not have the answer to. It's one of those things that some people can tolerate it, some people can't. I will say this, that we generally don't recommend spending a lot of time kneeling on your knee replacement. There is a plastic piece that is bonded to the back of your kneecap, and by kneeling directly on it, you can rock it free. My dad found that out the hard way. He had to go in for revision surgery because he rocked his kneecap loose. But as to why some patients can tolerate kneeling down for 10, 15 seconds to, get something out of the bottom shelf, and other patients find it painful, that's one thing that I don't think anybody can reliably tell you they know exactly why that's happening.
Is robotic assisted surgery better, and how would you compare the surgery to spinal fusion?
So how would I compare the robotic portion of it to spinal fusion? All right, so we'll start with, is it better? So I'm biased. I like to do my knees with robotic assistance. I think it's a great technology. I think that it gives us a more precise knee replacement. We get a CT scan of your knee before surgery. It gives us a 3D template that we can pre-plan your sizes and know exactly how much bone we need to remove in order to get through some of these places where the bone is no longer there, right? Part of the arthritis is that things wear away, and so we have to remove those defects where things are moved away. The robotic assistance also ensures that it takes the human error out of the cuts, right? We used to shave the joint surfaces away, and we place these cutting blocks onto the bone, and we could tilt and angle and kind of cheat the saw in whichever way we wanted and whatever we thought best, or accidentally do it even. And the robotic assisted eliminates a lot of that. The third thing that it does that I really think is a game changer is it gives us real-time measurements in the operating room so that we know when we're doing something that it's going to be well balanced, and the knee is going to go all the way straight, and it's going to have good bend to it. And I like it. That said, you're going to talk to some surgeon that does not do robotic surgeries, and they can quote you literature that patients do just as well without it. So, I mean, it's one of those areas that depends upon who you talk to. In terms of how it compares to spinal fusion, I know they're using robotics in spinal fusion. I don't know that much about it. It's not something I've ever really done. All I know is that robotics are, I think, the way of the future in orthopedics. They gives us real-time measurements. It makes the surgery a lot more precise. I had a mentor that once said, there's no field known to man in which robotics have entered and they have not caught on.
So I will piggyback on that. So we have another robot question. I've heard about the robot knee. What is that about, and does that make a difference?
So kind of like what we just talked about. Yeah. So it really is. So what it is it's actually a robot. We put a couple of sensors in and have a way to attach them to your leg during the surgery. And then we map out the knee and we match that to a CT scan. So we're actually telling the robot where your bone is in the operating room, and it can match that to the bony map that we gave it with the CT scan beforehand. And then there's a way that it can measure the space between the bones to make sure that those spaces are even when we're making our decisions in surgery. And then there's a robotic arm that we use that basically not only does it make sure that we make very precise cuts in the bones to help replace the knees, but it also adds a safety element to it. There's a big artery in the back of the knee called the popliteal artery, and it's pretty important. If it gets injured during a knee replacement surgery, it has to be repaired by a vascular surgeon. Otherwise, the patient can lose their leg. It's very rare for it to happen, but the robotic surgery program actually draws a digital boundary and it won't let the saw go there.
All right, so we're going to pick your brain here. So the question is, so I'm 35 with severe RA. I found out Saturday that I have mild osteoarthritis on the left knee. I have been for over 2 months under Tapper and prednisone, but feel it is not working. My body inflammation is down, but not my knee. I have a Baker cyst in the back. I saw my doctor today. Finally, he approved a referral for ortho. Does physical therapy work? Would that be okay for her to start?
I think physical therapy is a great. I think physical therapy is a great place to start. You know, we usually like to start off with less invasive and work our way up to more invasive. So if you can get your symptoms to resolve with some physical therapy, I think that's fantastic. I think that you already made the great first step of getting the rheumatoid arthritis under control. I think that's very difficult to control your knee arthritis symptoms if you don't have the underlying disease problem figured out, right? With these inflammatory arthritis problems, it's autoimmune. And if you're not controlling your immune system so it stops attacking your joint, it's impossible to play catch up on the back end. So you got to start primarily with getting the rheumatoid arthritis under control. Once that happens, like it sounds like you have, then you can address the knee in more traditional manners. You know, the rheumatoid arthritis unfortunately has already created the damage. So now it can be treated more like a normal osteoarthritis. And we can, you know, start doing physical therapy, start taking medications, you can try a knee brace. And ultimately, if it gets to it, you could try injections.
So just in case, so I just put up Dr. Daniel's contact info for anyone who has any questions, both office numbers, and then in the chat, there's a contact us form if you prefer to go that route. So Dr. Daniel, we still have a couple more questions. If a knee only hurts when doing stairs but not walking, does that mean there's a certain part of the knee that is affected?
Possibly. So sometimes we'll see that, you know, it's hard to say without looking at the x-rays and knowing more about the patient, but possibly, you know, sometimes we'll see that in patients who have isolated arthritis behind their kneecap. We call it the patellofemoral joint. So what happens when you're going up the stairs is you're really engaging your quadriceps muscle and you're putting a lot of stress across that joint, right? You got to pull your whole body weight up that step and you're doing it all through that kneecap, right on the top of your femur bone right there in the front of the knee. And so if that's worn out there when you're going up and down those stairs, that's at the moment that they're going to get the most stress across that joint. It's possible that there's some isolated patellofemoral arthritis there.
Can you comment on the presence of scar tissue as it relates to a knee replacement recovery?
Yeah, so scar tissue is probably one of the things that we worry about the most. I would say, you know, enemy number one in knee replacement is infection. It always has been, and it always will be. Enemy number two is probably scar tissue. When we talk about knee replacements, one of the biggest things that we have to hammer home and make sure patients understand is that getting the flexion back in the knee. So your knee will go straight, but getting it, that bend back, requires a lot of physical therapy, and there's a little bit of a time limit. You have about 3 months to get as much flexion out of it as you can, and after which point in time that scar tissue has really set and it's become really rigid. So you have to get the bend back before the scar tissue gets rigid so that the scar tissue heals long enough in order to allow your knee to bend. You know, every once in a while we see a patient that comes in that for whatever reason didn't get the motion out of their knee right away in that early post-operative period in that first 3 months, and they come in 4 or 5 years after their surgery and their knee doesn't bend much. And unfortunately, there's not a whole lot anybody can do to break up all that scar tissue. It forms circumferentially around the knee, and there's just no way to get it to release and to get the knee to bend more.
Are artificial knees larger than natural knees?
That depends upon what you mean by natural knees, but I would say most of the time, no. The knee is actually probably a little bit smaller. We don't like any overhang. So when we're talking sizing, we're talking inside to outside and front to back. And in that terms, most of the time, it's a little bit smaller. We remove bone and we don't want to overstuff it, is what we call it. We don't want it to be too big, because when it's too big, then that limits your motion. There has to be a little bit of undersizing in order to allow you to move the knee. In terms of the thickness of it for the length of the leg, we try to replace it as exactly as we can.
Can you talk a little bit about CBD cream? I have a few friends that it works well and a few that don't. What would you recommend?
So I think it's one of those newer products that, medicine hasn't caught up to yet. When we talk about new products in orthopedics and in medicine, a lot of times things come out and we got to do the research on to really know how effective it is. And these products come out and it's years before we have good data on it. This is one of those things that's just like that. I think I've seen a lot of patients that claim that it works really well for them. And as long as they don't have any other reason that they shouldn't be using it, I'm all for it. It's a relatively safe medication. It's topical. The idea behind it, I believe, is for to be anti-inflammatory, to bring down the inflammation. And as we talked about a lot during this talk, inflammation is the source of your pain. So if you can find a way like CBD cream to rub on the knee and get that inflammation down, I'm all for it. That said, I will say, don't go buy some, $400 cream. I know that the way that they make these is they have very small doses. And if that doesn't work, somebody usually tries to upsell you and tell you just need a larger dose. Well, that larger dose is usually 3 or 4 times the price. So start with the lowest dose, start with something cheap. If it doesn't work, I would say move on. If it does work, good for you. Keep doing it.
It's good advice. Will arthritis come back even if I have surgery?
With a knee replacement, no. So with a knee replacement, we have completely removed the joint surface. So arthritis comes from wearing away the cartilage. If there's no cartilage left in the knee, the arthritis won't come back. You got metal and plastic in there. It's going to stop it from coming back. If you have a different type of surgery, if you have a cartilage replacement surgery, yeah, the arthritis could come back. Like I said, most patients are not going to be candidates for those cartilage replacement surgeries. If you're having arthroscopic surgery, the arthritis never left. So it's hard to say whether it's going to come back or not.
All right, so we got a few more questions. What is your view on weight training? Squats, lunges, can any more damage be done?
I think that those are very good activities for patients that are younger that have good, healthy knees. Once the damage is kind of already there, you got to be careful. You got to listen to your knee. Some people will be able to tolerate that, but when you're putting heavy weight across those joints, it's always possible that you not necessarily create more damage, but you're going to put more pressure across that joint and you're going to cause more pain.
So the $1 million question, how soon can I drive after a knee replacement surgery?
Depends on a couple of things. One, what side are you having done? If it's if you have an automatic transmission and you get your right knee done, you need that right leg to drive. It's usually about 5 to 6 weeks. The left side, I tell people that, as long as you only need your right foot to drive, you're allowed to drive as soon as you're off the narcotic pain medication. That's still, driving under the influence if you're taking your narcotic pain medication and getting behind the wheel. So as soon as you're off the medication on the left side, you're good to go. The right side, it's usually about 5 to 6 weeks. I tell patients, have a relative drive you to an empty parking lot, practice a few emergency braking to make sure you have the reaction time back so you can go gas to brake if you need to, and then stay off at 84.
People tell me that the artificial knees weigh a lot more than the bone removed. Is that true?
That is true, but it's still such a small amount that most patients will never notice a difference. I've never heard of anybody complain of their knee being heavy after one of these surgeries.
I got 2 more here. How long does a cortisone shot last?
That is a very good question. It's very relative to the person. So I've seen patients get 12 months of relief out of them. I've seen some patients say it helps for 5 or 6 days. I will say that we can repeat them as often as every 3 months and safely not create any more damage in the knee. The first cortisone injection is usually the best one. So if you get 6 months out of the first one, for most people, every subsequent injection will last a little bit less.
Can I do any exercises to improve my symptoms, or will all exercises make it worse?
Absolutely not. Exercise is great for your knee. You got to find a way to stay active. Patients who allow their legs and their knees to get deconditioned, I feel like actually have worse symptoms. It's all about finding exercises that your knee will tolerate and won't flare up your arthritis. I think that focusing on aerobic exercise, walking, walking on a treadmill, using the exercise bike, elliptical is very good for pressure across the knee. Swimming is fantastic. And then anything you can do to increase the strength of your quadriceps muscle and help with your kneecap tracking, I think can be very beneficial.
And the last question we have here is there anything I can do to prevent arthritis?
For some people, yes. Some people, no. So the biggest thing is avoid damaging the knee. Most of the people that have an identifiable cause or had something happen that caused their arthritis, or those post-traumatic arthritis people, it's people who have had an ACL tear. It's the people who have had their meniscus surgery done in the past. It's people who have had a fracture that went through their knee joint that created the damage. For everyone else, the glucosamine supplement supposedly is supposed to help with that. The literature is mixed on whether that's true or not.
Awesome. Well, thank you, Dr. Daniel. So I skipped over just 2 slides or so we had questions. So just so everybody is aware, our next webinar is Thursday, November 11th, which is about back pain. What is sciatica? So if you haven't signed up, feel free to register on our website. And then the last one we have is December 9th, which is treatment options for shoulder arthritis. And then just some things that we've sort of already mentioned, but things we provide here at St. Francis and CJRI, some orthopedic surgery, sports med, spine care, CJRI, which Dr. Daniel is part of. And then, I'll leave this up just in case anyone has any questions for Dr. Daniel. And then in the chat, I left the contact us form. So thank you for everybody for joining us. We really appreciate it. Hopefully everybody found this very insightful and helpful. And hopefully we'll see you soon for another webinar. Thanks, guys.
Thank you, everyone.